moving forward with our interesting topics. It's a great privilege to introduce the moderators for the upcoming 3 sessions about pediatric emergencies and Kawasaki disease. We're honored to welcome Dr. Sameh Abdelazim, consultant pediatrician at a renowned hospital in Abu Dhabi, with a distinguished track record of experience across multiple Gulf countries. Alongside him, we are pleased to have Dr. Tariq Al-Azabi, an esteemed consultant, Dr. Tariq Al-Azabi, sorry, doctor, an esteemed consultant pediatrician from a leading institution in Abu Dhabi. He's also an examiner for pediatric consultant licensing at the DOH. They will moderate the sessions with their expertise and guidance.
Thank you, Dr. Raf. I would like to thank all of you for being here till this time, and inshallah, hopefully the last 3 sessions will be very fast, inshallah, but it's interesting. I promise the last one will be amazing because I know what is in it. So please don't miss the last one. So just I would like to introduce our first speaker of this session. I like to welcome Dr. Anas Abuhazem. Dr. Anas is an esteemed speaker and is American board certified pediatric cardiologist. He is a pediatric cardiologist, consultant pediatric cardiologist in a Reem Hospital. He will present today about Kawasaki disease update. Let us welcome Dr. Anas Abuhazem.
Thank you, Dr. Sameh. So we're going to talk about the latest update in Kawasaki disease. Some of you probably have attended this talk after the update came in 2017. So I made this lecture after the update in 2017. And then in November or December 2024, we have a new update. If you know the update from 2017, really not much have changed. Only a few points we will stress today. So most of this talk will be from 2017 with the addition of the things that were added in 24. So up till now, after more than 50 years, we still don't know what causes Kawasaki disease. We think it is an immune reaction to a viral infection because it happens more in the spring and the winter, because it comes in clusters, and IVIG works. So we think it is an immune reaction for a viral infection. It is highest incidence in Asia, especially Japan. More males are affected. If a patient develops Kawasaki disease, there is a 3% risk of recurrence. It's much higher in siblings and especially twins. There is definitely a genetic role for Kawasaki. Actually, I deleted the slide, but there is around 10 genes that have been identified that increases the risk of Kawasaki disease. It is more common in siblings. If there is one parent with Kawasaki disease, there is another risk of the child also having Kawasaki disease later in life. Interestingly, the highest risk, as we said, is in Japan, who people live in Japan. But if you're in Japan, Japanese live in America, you still have higher chance than American living in America, but less chance than a Japanese living in Japan. Somehow, so it is both genetic and environmental. So what really happens with Kawasaki disease? The immune reaction causes severe inflammation of the blood vessels, especially medium size, like the coronaries and the axillary. So this is a magnetic angiogram of a patient with Kawasaki disease, and you can see here, this is an axillary aneurysm. So not only the coronary arteries can be involved with Kawasaki, but also systemic arteries. Here we have the iliac. Believe it or not, just this Thursday, 2 days ago, I saw a 7-year-old who came with syncope. And just taking the medical history, the mother told me, when I asked her if there was any history of admissions, she told me when he was 3 months old, he was admitted with 40 days, 40 days of fever with no known cause. They did not know the cause for 40 days. At the end, it was blamed on CMV infection, and the patient got better and discharged. She came to me with syncope. I'm doing the echo, and I saw coronary aneurysms, never diagnosed. And I was shocked. The family has no idea. So I sat down, I told them, we found coronary aneurysms, And I think I know where he had the fever 7 years ago. And she said, you know what, doctor? He has aneurysms in his arms. We didn't know why. This same patient, not this picture, but 2 days ago, I saw a baby, a child with axillary aneurysms that they never knew why. So this patient 7 years ago had a severe Kawasaki that was undiagnosed and untreated, which we will touch based on this point, which diagnosing Kawasaki in young infants can be very tricky. So there are 3 stages: necrotizing arteritis, then chronic arteritis, and at the end, the chronic phase, the luminal myofibroblast proliferation. We can have small aneurysms or giant aneurysms or medium-sized aneurysms. The artery, once involved with a medium or large-sized aneurysm, it will never be normal. Even if the caliber comes back to normal, it will always be a stiff artery, risk of early atherosclerosis. So we used to say, once a Kawasaki, unfortunately, always a Kawasaki. Even if you're an adult, you have higher risk of early coronary artery disease. So the diagnosis, as everyone knows, to have complete Kawasaki, you have to have fever and 4 out of 5 clinical symptoms, right? We used to say 5 days. With the last guidelines, now 4 days is enough. So 4 days of fever is enough. And if you have a Kawasaki expert in your hospital, 3 days is enough, okay, to give IVIG. So unfortunately, right now, we still don't have one test to order for Kawasaki, but laboratory tests and echocardiogram are very, very, very important to make the diagnosis. So these are the clinical features of Kawasaki disease. What's this one? The rash, right? And rash can be many, many, many different shapes. But if it's vesicles or bully, it's not Kawasaki. The leg and feet changes. Nothing much can cause this except Kawasaki. When you have a swollen leg and that is shiny and red and it's tender, most of the time this is Kawasaki. Okay? You can have the cracked lips. This is the most common feature, by the way, the cracked lips and the strawberry tongue. The conjunctivitis is very specific. If the patient is having discharge or having swollen lids, then this is not Kawasaki. It's usually without discharge, and we call sparing the limbus. So what's the limbus? Is the immediate area around the iris. This usually is not affected. So you can see the redness in the periphery, but immediately around the iris, it's usually spared, okay? And the eyelid conjunctiva is not swollen, only the bulbar type, okay? The lymphadenopathy is the least common one. So we only see it in 40 to 50% of Kawasaki disease. Each lymph node cluster should be around 1.5 centimeter or more. So if it's a very small cluster of lymph nodes, this is not typical of Kawasaki. So now coming to fever. If you don't treat the patient with Kawasaki, usually the fever will last 12 to 14 days on average, okay? And can last even weeks. I've seen patients who went untreated for weeks. Usually resolves within 36 hours of IVIG. That's why if you give IVIG, we wait 36 hours before giving a second dose if the patient did not respond. Extremity changes we saw very distinctive. There is redness, it's painful, usually followed by desquamation. And if you follow those patients actually for few weeks, you will notice some white lines on their fingernails. We call them Bewes lines, okay? Sometimes the family knows, I know the future when I tell them after 2 weeks you will have this. And when they come for the appointment, it's like, how did you know? So it's like, this is typical of Kawasaki. So the rash can be many forms, but never vesicular or petechial or bulla, okay? I have this patient of mine who was a severe Kawasaki. If you have a patient with BCG, flare up again, think Kawasaki. We talked about conjunctivitis. So this is a patient, you can see the limbus is spared. There are no tears and the eyelids are not swollen. Oral changes, dryness, discoloration, or cracks, strawberry tongue. If you have ulcers or pharyngeal exudate, most likely not Kawasaki, okay? We talked about the cervical lymphadenopathy, usually more than 1.5 centimeter. Unfortunately, you cannot see this slide probably very well, but this is the slide from the latest update. And it is a very important slide. It shows you how to treat or diagnose complete Kawasaki and incomplete Kawasaki. Because it's not very clear, I will show more details in the next slide. Okay? But here it tells you about complete Kawasaki, and if you have incomplete, what labs to order. And at the end, it tells you which patients are high risk. So there are the Japanese criteria for high risk, and there is the American criteria for high risk. The American criteria, if the age is less than 6 months, or when you first do the first echo, there are coronary artery dilation. So if you have these two, these patients are high risk. And this makes a difference. We will see why. Now, incomplete Kawasaki, you can diagnose incomplete Kawasaki in an infant with only fever. So if you only have just fever for 7 days and positive labs, you can call it Kawasaki disease, even without any of the other 5. Just fever alone in an infant is enough. And I have seen one patient this year, and the patient I told you from 7 years ago who only had fever, no rash, no conjunctivitis, no cervical lymphadenopathy, no cracked lips, just fever. And they were missed. Both of them, 2 or 3 months old, both of them ended up with giant aneurysms. Okay? So this is the roadmap for incomplete Kawasaki. I have it on my desk. By now I memorize it, but I always give it to pediatricians. So if you have fever more than or equal to 5 days, so for incomplete Kawasaki, we're still asking for 5 days, but for the incomplete, we still need 5. So 2 to 3 clinical criteria, but the patient is not fulfilling all the criteria, then we ask for labs. Do always CRP and ESR, okay? If they are positive, you do these 6 labs, and if you have 3 positive, you can treat as Kawasaki. Or if the echo is positive, you can treat as Kawasaki, okay? So this is a very important table. Sorry? This is incomplete. So yeah, incomplete. You have 2 to 3. If you have 4, immediately give IVIG. But if you have only 2 to 3 clinical features, then we have the lab criteria or the echo criteria. The echo criteria, I know, I will not tell you. But I can tell you the lab criteria. Huh? Wallah, wow. Okay. So these are other scenarios for Kawasaki disease. Less than 12 months with prolonged fever. Infant prolonged fever and unexplained aseptic meningitis. Patients with fever and unexplained culture negative shock. We call this Kawasaki disease shock syndrome. Children with prolonged fever and lymphadenitis unresponsive to antibiotics. These are the usual laboratory findings: high CRP and ESR, anemia, high white blood cell, high platelets, sterile pyuria, liver enzymes are high, high amylase and lipase, hypoalbuminemia, and hyponatremia. If you have a patient with Kawasaki and low platelets, this is a red flag for shock syndrome, or DIC. So this is a very sick patient. Once you give IVIG, do not follow ESR, because ESR will go up with the IVIG. So just follow the CRP. After you give IVIG, we only do CRP. Okay, for the echo, this is my job. We always do it immediately when we're suspecting. But if you are very highly suspicious of Kawasaki, don't wait for the echo. Treat with IVIG if you don't have direct access to echo. Then we follow it one time again during the admission, if the patient is well, one again after 1 or 2 weeks, and then at 6 weeks. But for patients who are complicated, we do echo more often. This is a patient with giant aneurysms here, or severe dilation of the LCA. You can see it more better with color. So the left coronary artery and the right coronary artery are very dilated. So this is the Japanese criteria for high-risk patients. I told you the American criteria is Z-score or dilated coronary arteries. on diagnosis and less than 6 months of age. And this makes a big difference. Why? Because those patients, you can give steroids with IVIG immediately from the first dose. So you don't have to wait for resistance. The first dose of IVIG, you can give steroids with it. And we don't give methylprednisolone, we usually give just prednisone, 2 milligram per kilo IV divided every 8 hours for 5 days, and then taper over the next 3 to 4 weeks. Okay? So for resistant cases or high-risk patients, you can give steroids. If patient is not responding, you can give a second dose of IVIG or infliximab. Now people are giving, instead of giving the second dose of IVIG, are giving infliximab. We stopped giving pulse steroid. For people who still give pulse steroids, we don't give pulse steroids anymore, even for resistance to IVIG. Pulse steroid, the very high dose methylprednisolone, no more. Okay?
2 minutes.
Yes. Okay. So how do we treat those patients after you give the IVIG and they have coronary aneurysms? Okay, so you have a patient, you treated for Kawasaki disease, but there is coronary aneurysms. Depending on the size of the aneurysm, we give either aspirin alone, aspirin with clopidogrel, or aspirin with warfarin, or one of the new direct anticoagulants, okay? So this is for me, depending on the size of the aneurysm. Okay, so small aneurysm, you give just aspirin. Medium aneurysm, clopidogrel plus aspirin. Giant aneurysm, aspirin plus warfarin, or low molecular weight heparin. Okay. Now, if the patient has severe pain from the Kawasaki, don't give ibuprofen, please, because it will interfere with the work of aspirin. So just give paracetamol. Don't give ibuprofen in Kawasaki patients, okay? So long-term management, try to give them a healthy lifestyle, encourage exercise to the best of their ability. For the patients affected with aneurysms, we give them anticoagulation. Some patients with giant aneurysms, we give them beta blockers, sometimes ACE inhibitors. There's also a role of statins. So I will leave that to the subspecialist, will not bother you with this. This very long table, I don't memorize it, I have it on my screen. I even pull it up with the patient inside the room and we look at the map. Depending on the size of the aneurysm, it tells me how frequent I need to see this patient, how frequent I need to do the echo, how frequent I need to do CT scan or exercise stress testing, and what medications to give. So I don't memorize it. We look at it actually with the family together and come up with a plan. Okay, we talked about this, beta blocker, ACE inhibitors, and statins. Encourage physical activity to the best of their ability, okay? Now the things for the future, this is the last slide. Moderate or high dose aspirin might actually be going away. That's why I did not mention it with the IVIG. Right now we still give 30 to 50, but 2 big studies showed no benefit of patients who received aspirin, the high dose, and patients who did not receive. So I'm suspecting that the medium to high dose aspirin will go away in the future guidelines. Use of DOACs instead of warfarin, like Eliquis, apixaban, is becoming more, and it's easier for patients not to keep following INR. So this is becoming more in children now. And instead of second dose of IVIG, we're giving infliximab now, 10 milligram per kilo. So these are suspect will be becoming more in the future guidelines. And thank you very much.